Live now, sir.
Yeah. Okay. Good afternoon, everyone. I welcome all of you, or all of our pure urology viewers, for a very interesting topic about RIRS. RIRS still discussed most in all our conferences, and there is yet to explore and daily to learn. Each case is different. And we have today one eminent speaker about RIRS, Dr. Abhilash Antony, sir. So we will listen from him. So first, I'll introduce Dr. Abhilash Antony, sir. He is a consultant urologist in Kannur, Kerala since 2007, and he is founder and director of Specialized Urology Hospital since 2018. It is his own hospital, and he is expert in endourology, laparoscopy, and laser urology. And he is one of the early adopters of TUPLEP in India, and nearly performed about 5,000 TUPLEP procedures since 2020, which is really great. 5,000 is not less. And he is focused on advancing minimally invasive urological surgery in northern Kerala. So over to you, Abhilash, sir. Please start your presentation.
Thank you, Doctor. Thank you, Dr. Vati and Urology for giving me this opportunity. I will start my presentation. Are you able to see?
So before starting, sir, my one question.
Yes.
So you have done so many TUPLEP procedures. So why you chose to talk about RIRS?
Because Vati sir was telling to talk on RIRS.
Okay.
So we gave RIRS.
Okay, sir. Then when did you start your RIRS, sir? Career start?
RIRS, I think I first bought the that Viper was there, Olympus. Olympus
Okay.
Viper one scope was there. That I bought in, I think, 2008 or 9, something like that.
2009?
Yeah.
Way back.
Then I think initially they had 8 French or something. Then they reduced to 6 French. I bought the second one also. Then
Which
at
laser?
that time,
2009, which laser you were using, sir?
Olympus was there with Viper. I think Viper was the name.
Sir.
Olympus had this fiber optic RIRs.
Sir.
And that time laser was not available. But main use was, to pick up stones which has migrated after URS.
Sir.
Once you do URS and few fragments go into the kidney, then you go and pick up that. And also small stones, 4 millimeter type stones from the kidney.
At that time, few surgeons only in India were doing RIRS, I think.
Yeah, but when we go to conference and all, no, we just pick up these scopes.
Great.
Just out
of enthusiasm.
Yeah, out of curiosity. By around 2018, I think the chip-on-tip cameras started coming.
Yes, sir. Yes. And these cameras were too much fragile. These initially these scopes were.
Yeah. Yeah, very fragile. And they had some scheme also, like for 1 year, you keep this, any repair, you give 1.5 lakh, something like that. Like a CMC.
Yes, sir. Yes.
That is
Okay,
now.
Sir, now it is okay, easy. This fiber optic scopes.
It is easy. Disposable ones are very easy now.
Yes, sir. Okay, sir, we'll start the topic.
Yeah, we'll start. So this today's talk is regarding tips and tricks. So it is not much of a theory. It's rather the daily practice, daily routines, how we do things. Yeah. So the focus of this session is to safely perform an RIRS, achieve full stone clearance, enhance scope life, and enhance laser fiber and machine life. There are few techniques which we routinely follow. Routine indications are renal stones, ureter stones, necrotic papillae for clearance in pyelonephritis kidneys, tumors and strictures. Now, first and foremost is patient safety. Infections are our dreaded complications, especially when you are doing an RIRS in infected system. This bacteria goes into the renal parenchyma and form microabscesses. And that will cause a lot of extra admissions and IV antibiotics, and also very stressful to the urologist. So whenever there is an infection, when you see an infection, especially if there is a fever, pre-stent the patient, and whenever there is an obstruction, pre-stent the patient, especially if there is a fever with any amount of, even one episode of fever in the last 1 month of obstruction also, you stent the patient, because residual infection will be there, residual bacteria will be there. Once you go in, it will cause sepsis. And treat
So, sir,
UTI.
one question, sir, now.
Yeah.
So, do you regularly stent obstructing stones, irrespective of the size and duration of obstruction?
No, whenever there is an obstruction, you can always have a caution. That is, if there is a fever, even if there is one episode of chills, plan for a stenting.
Sure.
Okay. If there is
Yes,
absolutely no infection, then go for a primary. Especially when there is whenever there is obstruction, better to do a stent and take the patient later.
correct, sir.
Yeah. Especially when there is a fever, even if say last 1 month the patient is having obstruction, and there is one episode of fever in between somewhere which he has treated and he has cured. Still, you going for a staged RIRS with the stenting.
Correct.
Okay.
Yes.
Yeah, so the fever can be just one episode. In any of these, say last 1 month, if there is obstruction, then even if there is a one episode, then also you could do the stenting, treat UTI. Then pre and intraoperative antibiotics we give routinely. Okay.
How much, like during intra before the start of the procedure, or some time
We give
before?
in the say around we give in the 10 o'clock at 10 a.m. and we do the procedure between 1 and 2.
Okay.
3 or 4 hours time.
Okay.
Okay. Then for tight ureters also pre-stent and do staged RIR. So you counsel the patient regarding there's almost 10% chance there is always a tight ureter. There is a 10% chance that we will not do a primary and we will do a secondary stage procedure.
Do you regularly tell, sir, all patients this?
Yeah, every patient and every consent. In all consent, it is like that 10% chance of a staged procedure.
Okay, sir.
Okay. In
Because
consent
we
itself,
never know which ureter is going to be tight.
We don't know which ureter is going to be tight.
Correct.
Yeah. So it's in the consent itself.
Okay, sir.
Now, patient safety again. Another important problem is the intrarenal pressure. So you will try to reduce the intrarenal pressure. Use irrigation to cool the PCS due to the temperature of the laser. But with the lowest pressures, the primary option is gravity flushing, but usually insufficient. So we use pathfinders. And there is another option to use continuous irrigations with either pumps or with a lap insufflator. You can give the carbon dioxide into the NS bottle with a pressure set at 4 to 7 millimeter. That will give adequate pressure and also it will keep the kidney safe. I will show you the video later on for this. And
so which one do you regularly use, sir, among these?
For regular, we use pathfinders.
Pathfinders.
For large stones, when it's going to take 1 hour, then you go for lap insufflator with the pressure.
Okay.
Okay. And another important thing is you have to take out the scope and drain the stone fragments which is stuck in between the sheath and the scope every 5 minutes.
Okay.
Because rather than flushing, it is the return fluid that will determine the intrarenal pressure.
So you will totally take it out, sir? Scope?
Yeah, fully take it out fully because that in between that sheath and the you have to make the path free from stone fragments.
One more question, sir. The regular sheath size, what do you use? The axis sheath?
One we use 12-14 maximum ones. Western
12-14.
side. Yeah, big ones.
Okay. Then it will be difficult for primary RIRS.
Yeah, primary 11-13 is there.
Okay.
But if 11-13 is not going inside, we'll go for staging only. We don't use smaller sheet because
you will take out the scope outside total.
Pardon?
Every 5 minutes you will take the flexi scope.
Every 5 minutes, take out the scope fully.
Okay, sir.
The return path is more important than the amount of flushing doing.
Correct.
Okay. Then regarding access sheath, it will improve the irrigation, reduces the intrarenal pressures and temperature, prolongs the scope life, laser fiber life. Then you can go for a sheathless RIRS. The small size ureters are the primary RIRS with French scopes. So we always keep 2 spare 6 French scopes. Whenever you see when patient is having busy schedule, they want to go abroad and all, we do primary RIRS with a small scope, even if it is a small size ureter.
Yeah.
For large stones, more than 2 centimeters, And whenever CT is there and it is showing more than 1,400 units, HU, that is, even if it is a small stone, even if it is a 1 centimeter stone with 1,400 or above, then plan for a staged procedure. Because even if you break the stones, the fragments will remain there for HU more than 1,400. So you have to again do a second full RIRS in those cases. So whenever there is a large stone and a HU more than 1,400, you explain to the patient counsel the patient for 2-stage procedure.
Okay, sir.
And our routine is to limit one sitting into 3 hours maximum.
Sir.
Yeah. By the time the surgeon will be tired and the patient will be tired and will be tired.
Sure.
So it is better to, and also we will consult the patient also whenever there's a 2 or 3 centimeter stone, we will stop at 3 hours maximum. We will not go beyond that.
So do you tell how many stages you tell, sir, or like that?
For a 3 centimeter stone, we can always say 2 stage.
Okay, sir.
Okay. And there's a small trick also in between. You can say 1.5 stage.
Sure, sir.
So 1 full stage and another half stage, just to have the economical workout.
Okay, sir.
Yeah. Then regarding patient safety and low pressure, watch and free fall the return fluid. Return fluid should be dropping from the end of the access sheath always. Whenever there is a stopping of the return fluid, you have to take out the sheath and take out the RIRS and clean the lumen. Okay. Then with one finger, you can always feel for the warmth of the fluid. If it is excessive heat, stop glazing and do some flushing more, and also scope and do the freeing of the access sheath. Then renal pelvis and calyx damage may be due to excessive heat rather than blocked or high pressure. The excessive heat generated there will coagulate this calyces and mucosa.
Here, coming out each time is very important.
Yeah, coming out is very important.
Pelvic stone, you should come out intermittently and drain it.
Yeah, every 5 minutes you just take 1 minute break, come out and go in.
Okay, sir.
Okay. Then regarding stone clearance, we get a full stone clearance by a few steps. One is the pre-procedure also, you mark in the case sheet where are the stones. Okay, intraop for a beginner, I think always contrast study is good. But after some time, you can pre-operatively, you can mark these stones, and intraop, if you don't find these stones there, you go for a intraop contrast study. If you see there is no mismatch, then we don't do a contrast study.
Okay, sir.
Okay. And post-op imaging, post-op CT, we don't do regularly, but somebody is insisting for medical insurance and certificate and all, we go for a CT. Otherwise, we have a routine post-op ultrasound in our OP. We ultrasound we use.
You do, sir, post-op. Which post-op day?
2 weeks. We call the patient for 2 weeks, 1 follow-up, and send removal after 1 month for RIS. It is a routine.
Okay. You keep it for 1 month, sir? Any reason?
1 month, 1 month. And for 1 month. Initially, in the beginning, say 10 years back, I used to keep for 2 weeks and then remove. After that, the problem is patient is not fully satisfied with that edema, and pain is not so fully subsided with the 2 weeks. So we changed to 1 month.
Okay, okay, sir.
You just call for a follow-up at 2 weeks and assess the kidney. There is no much problems. Call the patient for stent removal at 1 month.
Any stent-related symptoms, they like, what do you give, sir? Like, if you keep for 1 month.
But we counsel the patient, it will be there, no problem, like that. And very few, maybe 1 or 2 patients in 1 year will not tolerate and they insist on removing early. All others, they are willing to keep for 1 month.
Okay, sir.
Yeah. Then always do for a relook RIRS at the time of stent removal. We have anesthetic, we give short GA with a propofol. That will just take 10 minutes. So whenever there is even a 1 millimeter fragment also, you go relook RIRS, the time of stent removal. So anesthesia, they will give.
So how do you justify, like, how do you patients, if you do relook RIRS for all stent removal, financial, how do you discuss? Like,
yeah, finance, that is what we routinely charge is like anesthesia. We have made a contract like 2,000, 3,000. Okay. And the total cost will be around less than 15,000. So
Access
still
if you
you
have to
can,
use flexiscope, you go inside and all that.
pardon?
15,000. All
No, I didn't get
so all
you.
that 50,000 you charge.
15,000 we can do a relook RIRS. It don't take much time, more than 10 minutes, not more than 10 minutes anyways.
Yes.
And scope damage is minimum because you just go inside and come out, that's all.
Correct, sir. And you keep, do you keep anything after relook RIRS? Like you will remove the stent, you don't keep
remove the
anything
stent, we
ureteric
don't
catheter?
keep.
Okay.
Yeah,
But
even if
I
there is
few
a,
of cases, I got fever, sir. So routinely
pardon?
I will keep a ureteric catheter for 1 day.
Yeah.
Next day I will discharge after
Ah.
relook RIRS.
Relook
Difference
usually
in-
doesn't have much problems. Then another thing is, if you have a large stone, say 1 centimeter fragment is remaining, then we counsel
Sir.
the patient that if it takes more than half an hour, then we will do the restenting and you have to come out one more time for stent removal.
Okay, sir.
Okay, when there is a large
Okay,
stone, 2
sir.
centimeter, and you have fracture powdered, but 1 centimeter stone is remaining in the
Okay, sir.
OP setting you are saying, then you say it is a very easy stone fragmentable. If it is taking less than 30 minutes, we will not stent it. But if it is taking more than 30 minutes, we will restent again. So that cutoff is there.
Okay, sir.
Okay. Then another important point is that you have to educate and counsel the patient regarding parenchymal calcifications. Most of the time, ultrasound we see small stones, 2 millimeter, 3 millimeter stones, and we go for a relook RIRS. But at that time, we will not see any stones. The calyces will be free.
Okay, sir.
Then when the patient is discharged, we just tell them that this we have found this in the ultrasound, but in RIRS we have not seen any stones. It could be parenchymal stones. Whenever you do ultrasound, it will be there.
Correct.
So you don't. So whenever there is match, you counsel the patient regarding parenchymal calcifications. So otherwise, they
Correct.
will immediately go out and do another ultrasound, and they will come back to you with the parenchymal calcification as labeled as stones.
In cases, in a few cases, if the patient is litigant, I sometimes call inside OT also attendants and show them.
Yeah, what we do is, we take all phone numbers and give them the calicial pictures in WhatsApp.
Sir.
Yeah, in drop you photos of these calyces and send them in the WhatsApp. So we have inspected
Oh,
all calyces. There is no stones. Whatever is there, in ultrasound we are saying is parenchymal calcifications.
okay. Good
Yeah.
option.
So that you will be free of litigation.
Litigants.
Yeah. Now regarding scopes, previously I told you fiber optic scopes are there. That is all outdated now. Digital scopes are in the way. So always try to buy the scopes in bulk to save. Minimum you purchase make a deal for purchase of 10 or more scopes. So you will get it at a cheaper price. Then you order one by one and start paying for 1 or 2 scopes like that. But deal has to be for 10 scopes. So that way we can purchase it cost effective. And always keep spare scopes because you don't know when it is going to fail. Also, one 6 French and one 8 French scope also you keep as a spare always. Because whenever you have 7 French scope is the main working scope, but when it is not going, you can access with the 6 French scope. Also, there are multiple single-use scopes and reusable scopes. For starters, these disposable scopes are available at 40 to 60K. That will work out to be around 5,000 to 6,000 per case. Okay. But the
Yeah.
advantage is you can forgive some mistakes like laser damage or flexion damage because you lose only 40 or 60K. Okay. For reusable scopes, it is truly economical.
Sir, what is that snake bone damage?
Snake bone, that flexion mechanism is there.
Okay.
That flexion mechanism they are holding snake bone. These manufacturers.
Okay, sir.
Okay. Now reusable scopes are more economical. It may be just 1,000 to 2,000 per case. Basically, we get around. We have got 150 hours for a scope. That was the maximum we have seen. Then almost 10% of the scopes last for 45 to 50 hours. Reusable scopes. Around 50% of the scopes die in 25 hours. So altogether, you can do an RIRS at around 500 to 1000 rupees scope charge.
Okay.
Yeah. So that reusable scopes are really economical. But you have to learn the basics, then only switch to reusable ones. When the sterilization is a big problem for reusable ones. So you have to have an ETO or you have to attach somebody who has an ETO.
So what do you use, sir, for sterilization?
For sterilization, weekly we do. I'm coming there. Okay. There are two
Okay.
options. One is ETO, other is flushing with spirit, Sidex, Parasafe, etc. So cleaning of the RIRS, exterior surface cleaning with soap solutions, all instruments with the lumen. All instruments, that is whether it's ureter catheter, dilators, whatever. With the lumen, we always flush with the saline, with the Sidex, and with the spirit. Okay. And you after flushing only you keep in Sidex for
So the
sterilization.
first step is flush with saline.
Saline.
Then Sidex spirit.
Sidex, and after taking out, after cleaning everything, you flush with the spirit also before the next use.
Okay.
Okay. Sterilization, ETO scopes, we routinely do all instruments. Weekly sterilization, that is laser pump, guide wires, ureter catheter, whatever instruments we have used that 1 week, we do ETO and pack keep it. And daily sterilization is with the Sidex OPG. Parasafe we don't have in our place, but in the North India, more people are using Parasafe. Formalin chamber is outdated. Also, whenever you are doing a fever case, or whenever the patient is having a post-op fever, even if one episode of small fever is there, you don't reuse that scope with the Sidex. You go for that particular scope which you have used. So we have at least 4 scopes running every day. So individual scopes, we know who has came with fever or who had post-op fever. So that scope you again send it for ETO.
Yeah.
Okay. So that way you can keep a check on the infections. Now to enhance scope life, the deflection mechanism is the most common form of damage. Then avoid excessive torque to the deflection mechanism. The snake bone mechanism breaks on excessive torque. So rotate the scope with the finger punch at the end of the sheath, not with the handle. Okay. Otherwise, if you rotate with the handle, there will be excessive torque. You use the handle just for the follow through of that rotation. You don't give force at the handle. You give force at the sheath with the finger.
Yes.
Then regarding working channel, laser damage during introduction and laser damage during firing. Also excessive pressure, irrigation and suction. All this damages the working channel. For that, laser is to be introduced in the straight position, and we never strip the laser fiber. And you see for any fiber damage also at the time of introduction. Whenever there is that pointer light will come out through the portion. Now regarding the outer covering of the RIR scope, the external damage on the trolley is one problem. Sterilization of the during sterilization also the external damage can happen from keeping things on. Then the outer PVC coating getting damaged during surgery with the stones rubbing against the surface. Then pressure damage from the outside within the access sheath when there are stone fragments. Then again, suction damage. When you do in-scope suction, the suction tube collapses inside, and the stones, whichever is there, that will pierce the plastic working channel. So use for a scope life enhancement, use larger access sheath. We usually use a 12-14 access sheath, and use shorter access sheath. Whenever you
and sir, length, how much it is, sir? Length?
Pardon?
Length, sir. Length of access sheath.
Length, I think 38 centimeter is the shortest one, 45 centimeter is the longer one. 28 and 42 centimeter and 28 centimeter. 28 is the shortest.
Okay, sir.
Okay. Then avoid narrow flexible sheath. Now flexible access sheath are there, 10 French and all. But the problem is the lumen is narrow, return fluid will be less, and friction at the bending will lead to scope outer sheath damage.
Yes, sir.
So initially we used to, last year, say 1 or 2 years back, we used to do a lot of cases with flexible access sheets. Now I think we have almost stopped. Now one company is coming out with a 12-14 flexible access sheet. So we have ordered it, but we have not started doing it.
Okay, sir.
That Clear Petra from Healthware, I think.
That is really good, sir. I've used in 2 cases, sir.
Yeah.
And it is very smooth and flexible. Very good, sir.
Yeah, the larger lumen also should be larger, 12-14.
Sir.
Okay. Then see for any fiber damage. Then regarding lasers now. Lasers, thulium lasers are there. Thulium YAG is there. Then there is a holmium YAG lasers with MOSES and dual pulse technologies. For our use, we use thulium fiber lasers. That is cheaper to own, cheaper to maintain. Unlimited fiber usage is there. Then effective power source for both and stone and soft tissues. So, for a urologist of choice will be the thulium laser fiber. Then holmium YAG is there. Initial cost is higher, maintenance is costlier. AMCs and blast shield are also costlier. Then there is another problem of limiting of the fiber usage. Some of the holmium YAG, they are limiting to 10 users, 25 users like that. So that time you have to purchase the fiber again after 10 or 20 users. Then another problem is whenever there is an unlimited holmium YAG, whenever there is a fiber damage, the blast shield also will get damaged. So you have to change both the blast shield as well as fiber whenever there is a fiber damage. So that will also add up to the cost. So in comparison, thulium fiber laser will be lasers of choice for practicing urologists.
Which one do you use, sir? Your routine practice?
Thulium fiber IPG.
Okay, sir.
Yeah.
65 watts, sir?
Yeah, I'll come to it.
Okay.
Yeah. Then thermal injury to ureters. That is another problem with the lasers. So limit laser power to 10 watts in the ureter. Fire for 2 or 3 seconds and then give a cooling period for 3 seconds. Again, fire for 2 or 3 seconds, then give a cooling period for 3 seconds. By that time, we have 2 advantages. One is our vision will become better. And the second is you will get enough time to cool the ureter so that the stricture will not happen. For kidneys, our routine frequency is 8 to 12 hertz and 1.5 joules maximum. That we continuously fire because of the large stones and all with the flushing. That is not a much a problem. I'll show you the 2 videos. Now this is the video of an RIRS, right lower calyx. We have some difficulty in negotiating into the lower calyx. Either you can get the scope going there by push and pull mechanism. You give a maximum bend and then you give a slight traction on the scope. Again, you give a bend, you give a traction on the scope. You pull the kidney down and you can reach the scope. That is one way of doing or accessing the lower calyx. Another way of doing is to give a percussion to the kidney. So from the outside, that will make the stones dislodge. You can see the good amount of flushing going on, and you can see the fragments getting cleared. You can see that the flushing is not being done. What we do is we use a laparoscopic insufflator and we use it as a closed system. You put it into the NS and you give a small pressure of say 4 to 7 millimeters, and that will have a adequate flow for good clearance for a large stone. Whenever there is a long session, you can easily clear the stones. I think you got the point there. That clap principle.
There.
That is very safe and also the adequate there is good flow is there and the pressure doesn't go beyond 4 or 7 millimeter mercury. So that will be around 40 or 70.
Never faced any infectious complications, sir, with this?
Not at all. It is better than flushing with a pathfinder. with the complication wise as well as also surgical wise, and your operating time will get reduced.
Okay, sir. Normally, I use gravity only, gravity method.
Yeah, gravity method, but with this 1 meter and all, I think we will not get enough flow.
Yes, sir. Yes. Few cases you have to struggle.
Yeah, but this gives good clearance, and also it will limit the pressure. It will not go dangerously above as in a pathfinder.
Sir.
So that way it is advantageous.
Sir.
Video.
Regarding lasers, laser is the chief power source for a urologist. So initially I had a luminous 20 watt laser. I used to go for the stones with that. Then I thought it was inadequate. Then I bought one, that was in 2017. Then I bought one 60 watt IPG petroleum fiber laser around in 2018. I was very happy with the laser. So then for additional work, I bought another 35 watt machine. And then again I bought one more 60 watt machine. All these machines are still working and they are all fine, doing good work. The point is regarding 60 and if you compare 60 and 35 watt machines, the powdering quality is slightly different in 60 watt machines when you compare to 35 watt machines. Also for tulip, that is for enucleation also, you can do it with 35 watt, but that is slightly slower process. So if you have a little deeper pockets, you can go for a 60 watt machine. That will give you work satisfaction more. Now coming to the laser settings, I thought of all three machines, you can see different settings. Yeah, for URs we use 0.6 joules and 10 hertz, usually 6 to 8 watt, not more than that. For hard stones, you get 1 joule or maybe 1.2 joule. Accordingly, you will reduce the frequency. The point is, every time you use for 2 or 3 seconds, give a 3-second pause. Never use continuous laser in your ureter. Now coming to the kidney, you can use the popcorn or the dusting mode at 0.2 and 100 hertz. That is around 20 watts. And for harder stones, you can go for 150, 1.5 joules and 8 hertz. If it is more than 8 hertz, there will be flickering in the monitor. So maximum frequency we will get is around 8 to 12 hertz. You can't go more than that. And the power you can maximum keep at 1.5. So maximum of renal lacing will be around 20 watts. You can't go more than that. But still, we prefer a 60 watt laser because the quality of fragmentation is different in 35 watt and a 60 watt machine. Now coming to enucleation of prostate, we keep the power at 1 joule and 45 hertz. That can go up to 60 watt also, and coagulation at 0.3 and 100 joules. So these are the typical power settings we use for the routine urology work. Important material which I have found very useful for.
I'll just finish it and then we'll go.
Sure, sir.
Okay.
Coagulation at 0.3 and 100 joules. So these are the typical power settings we use for the routine urology work. Important material which I have found very useful for a urologist is the thermocol. Okay, you may be wondering, but for laser fibers, the maximum damages happen when handling. See this scope, this fiber has damage in the midway. Okay, it's a 200 fiber. Now it is of no use after around 5 to 6 hours of lacing. So what I have found a method to foolproof the damage during handling is to make a small gutters in the thermocol box, thermocol paper card, and keep the laser in such a way that it doesn't come out. So it stays there without any damage, and you can stack any number of laser fibers. It's a 200, 600 fiber. You can label it and also keep it. This is the 1000 fiber. This is a 150 fiber. This is also very useful. Now all these are very fragile fibers. So if you keep it like this, you can have the laser for a long time. You can save the fiber cost. You can see the 200 fiber. So if you keep this protected, we can do much more economical work regarding the laser fibers. So I have my colleague Dr. Kiran with me. He does most of the URS and RIRS in this institution. So Dr. Kiran, you use this
Yes, sir.
reusable scope.
Yes, sir. Vesimed.
Vesimed is there. And another one is Biorad.
Biorad.
Both of them are good, equally
Yes,
good.
equally
Mobility.
Good. Mobility is good.
In addition, you have disposable scopes also available. And size, which one is this? 7.5.
7.5.
7.3. Yeah.
Yes.
Another smaller one is also
6 French also.
6
we are
French
using.
also is available. Whenever you need a primary URS and you have thin ureter, you can go with the 6 French. Okay. So initially, what we do is we routinely do
URS.
URS
Yeah.
with a 6 French
With
scope,
6 French.
and you use guide wires, zebra guide wires.
Yeah.
Okay. And if it is not going, you can use thermo guide wires. Okay. Then we introduce sheath.
Sheath.
Okay. Regarding sheaths, there are so many types of sheath in the market. This is the 1113.
1113.
1113.
Yeah.
Okay. You routinely use the 1113
For
or
primary case, we will use
1113. We
For
use
standard-
this Boston Scientific exclusively.
Yes, sir.
Yes, sir. Because it has got a very nice hydrophilic coating and it glides smoothly inside. We are not very happy with the other type of sheets. These have rugosities now after 2-3 use, but this will stand a long time, maybe 10-15 cases, and still it has that hydrophilic coating which lasts. Okay. Same with the 1240.
1214.
So when there is a primary URS, you use the thinner one.
Yeah.
When there is a standard patient, you try to use the biggest
Biggest one.
lumen.
Yeah.
Yeah. Why? Because you get the free flow of
Free flow.
return fluid,
Good clearance.
good clearance, stone clearance. The fragments will come easily.
Yes.
Okay. So that is sheets. Then you have the fans also, flexible access sheet.
Flexible.
The tip is flexible. Okay. Now this is an old one. We have excluded, discarded one. So the tip is flexible. Regarding pressure irrigations, we have a modified pathfinder. Okay, that is a slightly bigger one than the traditional ones we use in the routine ORs. Okay, the bigger one will help you with reducing the pressure. In contrary to what you think, when the size gets bigger, the pressure, the applied pressure becomes lower. So the bigger pathfinder will help you reduce the intrarenal pressure and also increase the volume of the fluid. So that is regarding pathfinder. Then at times you enter without a sheath, that is sheathless primary. Okay, for that you will need the help of a bi-wire, that is both ends are, again Boston Scientific has it, both ends are hydrotip and followed by PTFE coating. Okay, so then that is helpful to back thread the RIR scope. Once the guide wire is inside the lumen, you can back thread the easily without damaging the
Scope.
access sheath. Okay, and then you can thread it into the ureter. So that is the purpose of the bi-wire. That is both ends are floppy tip. Now Clear Petra, I think Healthware is coming with the one side thermo and other side flexible zebra coating. That is also available. They have not introduced in the market, but they think they will be soon introducing it. Another instrument we often use is the basket. So there are these open type baskets are there, closed type baskets are there, zero tip baskets are there. Practically we don't use it much because anything, whether it is a slab, whether it is a stone, whether it is a tumor, everything we deal with the laser. So practically we don't use it much. When you are using a 1113 sheath, the sheath will go and will get deposited or will get positioned in the almost just after the crossing vessel or just below the crossing vessel. The problem is that when you introduce the RIR scope, the scope will go and get stuck on the mucosa. It will not come out like this. It will get stuck in the mucosa. In such a case, what you do is you push-pull the sheath. You remove the sheath and advance the scope at the same time, like this. So you will not damage the ureter mucosa. That is a very simple technique which we often find it useful. You withdraw the sheath on the, okay, you keep it at this position where it is the mucosa is stuck. Then at the same time you withdraw the sheath and advance the scope. So you will get enough space for maneuvering the ureteroscope. Again, tight calyces. When you have a tight calyx, you want to go more of here. You may not get the bend here. So what you do is you pull the kidney down, again slightly advance it, pull the kidney down again. With a repeated movement like this, you can advance more and more into the defecate calyces. You will get secondary deflections in addition to primary deflections. These are a few maneuvers which will help you with the accessibility. This is a picture of a RIR scope which is damaged. You can clearly see the snake bone or the fish bone that is damaged. This usually happens, because of the excessive torque given to the scope in the bend position. In the bend position, when you give a torque, the snake bone get damaged. So a rule of the thumb you can apply is, you can twist the scope with this hand, not with the handle. With the fingers you can twist the scope. So you give that much only pressure to the torquing mechanism and you follow through with the handle, not you twist with the handle. Handle is a passive movement and the fingertip should be the active movement. That way you can prevent the damage to the snake bone and you will get a better scope life. Another common mode of damage is damage to the outer PVC coating of the RIR scope. That usually happens from injury or damage from the exposed metal tip of the access sheath. So whenever each time you come back into the, each time when you withdraw, you come back through the access sheath and you see for the access sheath any damages. Whenever there is a metal strip exposed, just discard the scope, discard the access sheath and never reuse it. Also, you can see the external of the access sheath for kinks. So whenever there is a kink, and then don't proceed to use it again. This will help enhance the scope life as well as patient safety. Another most common form of damage to the scope is the damage to the outer sheath. Outer PVC coating gets damaged. So most often this happens when you have a long or RIRS session with a large stone. You tend to push and pull the scope in between a lot. So what happens is the stone fragments will come and get stuck in the sheath, and this will that friction between stone fragments, the sheath and the scope will damage the outer covering. So that you can prevent by periodically coming out and removing all the fragments which has been stuck in between the sheath and the scope. Regarding fans, that problems are little more because of the longer instrumentation and the thinner working lumen. Now I think Healthware has come out with a larger lumen. This is at 11 French fans. They have come out with the 12-14 and 11-13 fans. So that will help reduce the outer sheath or PVC coating damage of the RIR scope. So better go for a bigger sheath whenever possible, even if it is a fan sheath or a regular sheath. To give an insight into the working of a scope, I have cut open the scope. You can see the thin plastic, fragile plastic tube, and that is our working channel. Any damage, any simple violation can lead to the damage of the working channel and failure of the scope. See how thin and how fragile the plastic tube is. You respect this tube and you get a good working scope. As a conclusion, I would say RIRS is going to become the main mode of stone removal in urology. RIRS is going to pick up in a big way. Previously, say 5 years back, I used to do 5 PCNLs on the average every day. Now I hardly do a PCNL every 6 months. Only for a very huge stone I do a PCNL. So You have to learn this RIRS. You have to be economical, and judicious use of these instruments will take you a long way in the urology practice. Thank you.
Nice video, sir.
Thank you, thank you.
So, few questions, sir. One viewer has asked, do you routinely do relook RIRS for all stent removals?
We do ultrasound in OP. So when the patient is coming after 2 weeks, to do an ultrasound in the OP and see for the any residual stones. If you have even a small fragment, you recommend for a relook RIRS. If there is no stone at all, then you simply remove the stent without RIRS.
Okay. One more question, sir. You told about enucleation settings, sir.
Yeah.
So, if you are using 35-watt laser, what do you use your settings?
35 watt, you give more of 1 joule, 1.5 joule. With 18,
1 joule.
Yeah, with a 17 or 18 frequency. 1.5 joule.
1.5 joule, 18.
18 frequency with 35 watts.
Second thing is, sir, like in after how many cases do you change your access sheet?
Around 10 to 15 cases we get per access sheet.
It lasts around
Yeah, by that time it gets
well,
damaged.
maybe 6 to 7. That's why I'm asking. Sir.
Yeah.
10 to 15 is good enough.
Yeah, good enough.
And one more very difficult scenario. Even a patient comes with a very narrow ureter and a tight suspensory ligament, young male. Then we have stented again after going inside after 2 weeks, the ureter is tight. And access sheath is not going beyond VUJ, then what do you do in that condition?
You have that smaller scope? 6 French?
Smaller scope.
Yeah.
6 French.
6
Sheathless
French.
RIRS.
Yeah, sheathless. Very smaller stone. If the stone is also big, then go for PCNL. You have no choice.
So
if it
what is
less
your
than,
conversion
say,
rate to PCNL?
Pardon?
Conversion rate to PCNL, sir, during RIRS.
Yeah. What
Do
we
you
do? Almost no conversion. Basically, we say if it is a more than 2-3 centimeter stone, you counsel for PCNL. If it is a large stone, otherwise the patient should insist. I am willing for multiple sittings.
So to what is your size limit for RIRS in your practice?
We had our colleague Suraj was there. He was doing RIRS in 5 stages for a large stag-on calculus. He achieved full clearance from our hospital only, but it took 5 sittings.
Any
The patient is
complications, sir, like
yeah, but
increase in
he went up without any problem. The problem was that he was a high cardiac risk, and he did not want the PCNL at any cost. So we have had patients even 5 sittings and full stone clearance. Still, patient is okay.
Okay.
Only thing the surgeon and the patient should accept that it is going to take at least 5-6 sittings like that. Each time 2 or 3 hours.
Viewer has asked a question. So what is the difference between 35 watt and 60 watt in RIRS in TFL laser? What do you feel?
The 60 watt, it has got a good powdering mechanism is there in 60 watt. 35, you will not get that quality of powdering is different. Dusting and fragmented popcorn, etc.
So what do you regularly use? I saw you were using dusting and fragmentation, not fragmentation and popcorn.
And that also almost same thing. Everything is the same only. 0.2, 0.3 like that for popcorning. For
you
fragmentation,
do popcorn, sir, regularly?
We do initially, means if it is a large stone, go for fragmentation at 1.2 or 1.3 joule. Around 12 or 18, maximum 18 frequency, not more than that. You will not get more frequency because of the flickering in the screen will happen.
So
Once a lot of fragments are there, you go for the popcorning. Once in all calyces, there are lot of fragments. So initial fragmentation is better, then followed by popcorning.
So you have stented a case, sir. Suppose there is a case scenario, you have stented it. And after going inside, there is less outflow from the access sheath.
Yeah.
Kept the access sheath, outflow from the access sheath is very less. Then
It's
what do
still
you do
there.
in that case?
No, if
Yes,
it is
sir.
no outflow, then you have to change to a smaller scope and see. Okay, or a bigger
Smaller
sheet and
scope.
see. Yeah, bigger sheet, smaller scope like that. You have to have a return fluid.
If no return fluid, then have you cancelled any cases or something
No,
like what
no,
did you manage?
always it is there. Not cancelled due to, yeah.
Okay, sir.
Yes,
So
sir.
presenting rate, how many cases do you do, sir? Primary RIRS and how many are presenting like in
Almost
your practice?
80% of cases we can go for primary with 11-13 sheath.
11, 13.
11-13. That is small stones, less than say 1.5 or 2 centimeter. More than 2 centimeters, then always go for a staged procedure.
So what will you advise for juniors who are starting RIRS to about internal pressure? Rise in internal
Use
pressure.
a bigger sheet. That's all. Simple. Try to
Bigger
use
sheet,
bigger
12,
sheet.
14.
Yeah, 12-14. That Boston Scientific. That is a good sheet. It is sturdy and it doesn't collapse under pressure. Initially, we
So
used
why
to
did you stop, sir? Fans RIRS?
that is
Any
scope life is
complications,
limited.
specific complications?
No specific complication. The scope life is very much limited. Economics doesn't work out.
Which scope now you will tell, sir, for juniors to take like flexible scope? No conflicts of interest, like in your practice. Which fiber optic scope
We have
or digital scope?
yeah, for digitals we have reusable scopes. We don't initially we used to buy in bulk disposable ones, 10 scopes, 20 scopes like that. Now we buy in bulk reusable scopes. So
Which
two
one you
companies
do
there, that
recommend?
Visimed and Biorad. Both of them we have. So one lot of 10 Biorad will come, then another lot of 10 will come, like that. Both are equally good. So we don't, give monopoly always. At least to have two vendors, because sometimes these are all coming from China. I think if there is some logistics problem, then they may stop. So always keep two vendors.
One more common problem, sir. Suppose there are 5 RIRS cases you have planned in a day,
Ah,
and you have two scopes only, like I have. So
ah.
how do you plan and how do you sterilize that day, the scopes and all?
We have two processes of Biorad and two processes of Visimed. So there are 4 processes. Okay, scopes you have plenty. You have 10 scopes of remaining.
So for beginners, what will you advise, sir? Those who have only one scope and who do
And scope
like
OPG, side X
home
OPG,
practice
flush and keep it for 5-10 minutes. That will do.
only with saline, sir.
No, OPG, you see, you keep in the side X.
Side
Side X
X.
OPG is there. You keep it for 10 or 15 minutes. 12 minutes is recommended time. The problem is we don't flush inside.
You flush it with side X.
Side X inside the scope. And then after taking out, flush it with saline and then flush with the spirit.
Spirit won't damage, sir, working channel.
It doesn't have
We never
no
use
problems.
spirit.
But
I use
essence is
sometimes
different.
gentamicin solution, but spirit never tried.
Spirit we always do.
Sir.
It doesn't
In that
damage.
way, do you get anytime fever post RIRS?
Except once in a while we get fever, but there are infected cases. So the problem is once you get an infected case, you remove that scope for ETO. Send the scope for ETO and then only use that scope. Identify that scope, whenever you have a fever, whatever instrument taken for that case, whether it is uric catheter, whether it is zebra guide wire, thermo guide wire, whatever instrument, pathfinders, everything will go for ETO. Then only it will come back into the OT table.
Nice, sir. Nice presentation. And once again, we'd like to hear from you about Thuplep. You have done 5,000 cases.
Yeah,
I am also more
almost.
into Thuplep.
Yeah, one
So I
day.
am still in. I
Yeah.
have not done many cases like you starting phase. So again, we will connect after some time.
Yeah, we'll do one day.
Very nice interactive session, sir. Thank you so much.
Okay.
Thank you all.
Welcome.
Urology
Thank you.
viewers. You sir, take care.
Okay.